Welcome to the Moss Report with your host, Dr. Ralph W. Moss.
So today I'm speaking with Dr. Abdul Slocum from the Chemothermia Clinic in Istanbul, Turkey. And we're going to talk about how that clinic originated and what it does, what makes it unique and distinctive. So welcome to the podcast, Abdul.
Thank you, Ralph. Thank you very much for inviting me to your podcast. And I hope it will be a nice, productive talk.
I'm sure it will. So I was looking back at my calendar, my diary, if you will, and I see that it was literally three years to the day that I was at your clinic, visiting your clinic. So time goes by fast.
Time passes so quickly, so quickly.
Yes, definitely. So, and we've been in touch, somewhat through emails and so forth, but it's just a tremendous pleasure to me to catch up with you and find out what's happening. As you know, I was very impressed with your clinic, and I think it's really a great thing that you've done to extend the type of treatment that we believe in, further east, if you will, in the world, so that it's not just all about Europe and Germany and Austria, but also extends to Turkey, which is a unique country that many of our listeners may or may not realize, that this is the only country in the world that spans both Europe and Asia. And it's really a fantastic place. If listeners haven't visited there, I would strongly urge you to do that at the first opportunity to do so. But we're not talking about tourism here. We're talking about medicine and about cancer in particular. I think the best way for me to introduce this subject would be for you to explain to the listeners what the name chemothermia means, because I think it's a brilliant name and it kind of encapsulates exactly what you're trying to do. But I'll let you describe and explain that.
Thank you very much for the introduction, and it's a pleasure to talk with you again. And now, first, I'd like to start with our clinic has been founded by my colleagues, Professor Berkarda and Dr. Kesici. And we've been working together for around 10 years or so right now. And we're a clinic that's founded by physicians. We're a medical oncology team. And we come from the conventional world, and we're applying so-called complementary therapies. And by coming from the conventional world, we founded the clinic with the question, how can we improve outcomes? And the current treatment protocol that we're applying comes with the main aim of improving treatment outcomes, and without rejecting the sound evidence that comes from conventional medicine, combining science-based complementary therapies with such protocols and trying to improve efficacy of conventional treatments is what we've been trying to do. And in the last 10 years of time, by doing so, until now, we've treated thousands of patients, and we've currently published 7 papers, and our 8th paper will be coming out soon in the upcoming months. And all of these papers document how much treatment outcomes can be improved with a wider way to approach medicine and treatments of cancer patients.
Yes, and I think it's worth emphasizing when you say you come from a conventional background that not only are you and your partners all medical doctors, but Dr. Berkarda, I apologize for my pronunciation, but it looks like Berkarda to me in
exactly.
English term.
Thank you.
So, he represents and he really occupies a unique position within the oncology
Definitely,
field in Turkey. I mean, from my understanding, he was really the founder of medical
definitely.
oncology in Turkey, which is a tremendous achievement because it's a large and in many ways very progressive country, which would surprise a lot of our listeners, I'm sure. But the medical center in the part of Istanbul where you are located sort of resembles the Texas Medical Center in Houston or something like that. It's there's nothing backward about it. It's up to the standards of any kind of Western medicine that you would want to comment on. But really, his history, being a man in his 80s now, his history goes back, I think, to the 1960s, right? And I think he
Yeah, yeah.
trained originally in the U.S.
Yeah,
And
exactly. I'll explain Professor Berkarda's history. Now, Professor Berkarda, as you said, is the first medical oncologist of the Turkish nation. Following studying medicine in Turkey after graduating, he did his internal medicine residency in Istanbul, and which was followed by a hematology oncology specialty, again done in Turkey. And following these specialties, he also did a cardiology specialty in France, in Paris, which was followed by a medical oncology specialty done in the United States. And following completing his medical oncology residency in the United States, he came back to Turkey in 1974 and founded the Department of Medical Oncology at the Istanbul University in Turkey. By being the first medical oncologist of the Turkish nation, he's been the leading figure for around 40 some years right now, and practicing medicine for around 60 years or so right now. And the reason our clinic was founded is actually especially his life experience of practicing conventional medicine for so long years and seeing shortcomings of medical treatments, especially in the field of oncology.
yes,
And his experience and sound background has supported us and encouraged us to come to these days. And his service to the community is still continuing with our clinic's works. And so, as I said, he has four specialties actually: internal medicine, hematology, cardiology, and medical oncology.
amazing.
So it's an amazing biography and background that he has. And following doing such specialties and practicing standard conventional oncology for many years, he has come to the point of founding our clinic and supporting uh, innovative therapies being applied to patients with the main aim of trying to improve outcomes.
But I think what's really interesting is that here's a person who is totally immersed in conventional oncology, who, after a lifetime of practice, really came to the realization that it was not adequate for a lot of cases, especially for people with a very advanced cancer. Am I correctly stating that?
Definitely, definitely, exactly. That's exactly how he will state it, I believe.
So, it isn't a case of somebody who was sort of alternative to begin with, and then was just looking for some way to express an anti-establishment point of view, which sometimes maybe occurs. But this was an instance where somebody, after so many years, came to the realization that we needed something more, and he didn't reject what was good in what he had previously done, but he significantly changed the feel, if you will, of the clinic and of what he
E-
wanted to do.
Exactly, and like to open up what you've mentioned, like he's also founded the Society of Chemotherapy in Turkey. Actually, like
Yeah.
he comes from, he's
Yes.
that like he founded the Society of Turkish Chemotherapy in Turkey.
Yes.
So like and he has educated almost like a good portion of the currently practicing medical oncologists in Turkey, and has practiced guideline-based treatments for around 25, 30 years or so.
Yes.
And his after being such a figure in standard medicine in Turkey, as you said, it's been a kind of realization to him.
Yes.
And what's led him to have this realization is seeing the need for improvement and shortcomings, especially in advanced cancer patients, and where there was need for questions to be asked. And we've, as a clinic, as you said, we don't come from an alternative background, and our main ultimate goal has always been not rejecting what we've been educated about, but uh, asking the question, what can we add on to this? How can we improve this? What else can be applied? And looking for sound evidence that in regard to what can be used to treat patients in an evidence-based manner. And that's the basis of our current treatment protocol.
Yes. And it's very impressive to me that you've produced these 7 papers because, as we know, doctors who practice complementary medicine are so uh, overwhelmed by the practical difficulties of doing that sort of treatment, how time consuming it is, for instance, compared to just purely conventional guidelines uh, guided treatment, that they rarely have time or energy to produce papers, which are, it's a difficult process. I've been involved in producing several scientific papers over the years, and it's just, people have no idea how exhausting that is. And so it's very impressive to me that, given that you have, what, 3 medical oncologists on staff, at the clinic, but that you've been able to turn out in a relatively few years, turn out
Yeah, yeah,
now 8 papers, and these papers are very, very good. I mean, they're really up to a high standard because they're written in the same way that any paper would be written for a scientific audience. But I think what it shows is that in individual cases, there can be extraordinary outcomes based upon combining the best of the conventional with the complementary treatment. So I salute you. And I felt this way when you only had 2 papers and one
yeah,
in
yeah, yeah.
press. And boy, you guys have really moved fast and furiously to get this,
Yeah,
to get the word out. So I think, going back to my original question, it seems as if the name of the clinic, what it's saying basically, is the combination of chemotherapy with hyperthermia. I mean, that's how
yeah, yeah, yeah.
anybody would interpret this. But
Yeah,
you
yeah,
also do.
that's how we started out, because we started out with chemotherapy and hyperthermia initially. So that's where our name comes from.
Yes. And so it's based on the principle of which there's quite a bit of evidence that hyperthermia improves the outcome of various kinds of treatment, not just chemo, but also radiation and other, and immunotherapy and so forth. So you've added this very important adjunctive or additive component of the treatment, and you're using basically the same type of approach as the German and European clinics use, but now
Yeah,
it's
yeah,
given a distinct Turkish flavor, as it were. Um, I'm also very interested in the fact that, in many people's minds, I think you're associated with the metabolic approach and sort of the insights that were gained by Dr. Tom Seyfried of Boston College, who has written the book Cancer as a Metabolic Disease. So could you explain how you view that and how you use that in your own practice?
Thank you. It's a very good question. Now, first, as our name states also, when we started back 10 years ago, we initially was only applying hyperthermia. And as years passed, as our research continued, we've added on the hyperbaric oxygen therapy, the ketogenic diet. Also, we've embodied with the Warburg hypothesis and the metabolic basis of cancer also, and actually during our research and after starting to incorporate metabolic therapies into our treatment protocol, me and my colleagues, we came across Professor Seyfried's book Cancer as a Metabolic Disease, which was fascinating to read, and we were very surprised actually because it's great book, great work, and we were applying many treatments that were mentioned in that book at that time, which we were very happy about because we had came across the same kind of evidence that was sitting there, and Professor Seyfried had done a great work in bringing all of the information and sound evidence together. And following that book, we've been in contact with Professor Seyfried and are collaborating with him and trying to incorporate metabolic therapies together with conventional therapies. And currently, as these years have passed, our treatment protocol currently is consisting of mainly 4 components of metabolically supported chemotherapy, which we've named it as, and the ketogenic diet, hyperthermia, and hyperbaric oxygen therapy. And if I'll open up on especially what is metabolically supported chemotherapy, where does this name come from, and why is it called like this? And now, firstly, metabolically supported chemotherapy, if you put it into basics, it's a way of applying chemotherapy which we're putting into the field and recommending for conventional practitioners to apply chemotherapy in this way. It's a way of applying chemotherapy while the disease is under metabolic stress. So it's we can say it's applying chemotherapy at the correct time and metabolic condition, and using the metabolic vulnerabilities of cancer cells to cause stress on them, and applying cytotoxic drugs at that time that they're weak. It consists of mainly a 14-hour fast prior to applying chemotherapy, and which starts from the previous evening of receiving chemotherapy, and then applying insulin to cause acute metabolic stress on cancer cells prior to having chemotherapy. And together with this, we also apply hyperthermia concomitantly with chemotherapy, which is a treatment, as you've also said, with there's sound evidence in. It's a treatment that exploits the heat sensitivity of cancer cells and has a direct cytotoxic effect on itself. But besides causing direct cytotoxicity, in several studies it's also been shown to increase the efficacy of chemotherapy and radiotherapy by sensitizing these cells to these therapies. So it's a treatment that both has a direct cytotoxic effect, but also has an effect of increasing the efficacy of conventional chemotherapy and radiotherapy.
Yes.
And together with this, we also apply hyperbaric oxygen therapy, which, as many, it's well known in conventional medicine that tumors are grow and enlarge in hypoxic environments, and tumor hypoxia itself has cancer promoting effects. And this hypoxic environment also increases the glycolytic dependency of cancer cells, which promotes both resistance to chemotherapy and also radiotherapy.
So basically, to explain about hypoxia, I mean that it's the lack of oxygen. So in a situation where there is insufficient oxygen, what you're saying is that the cancers thrive in that situation. So that's
exactly.
Yeah. Okay.
And we by applying like hyperbaric oxygen therapy is applying pressure in a high oxygen concentration environment, and which increases, it dissolves oxygen in tissues, and it will increase oxygen levels in besides, even if there's a good circulation, it will dissolve oxygen in the tissues, and it's a good way to counteract tumor hypoxia and the hypoxic environment that the tumor thrives in. And so it will it targets the unfavorable consequences that hypoxia causes. So our treatment mainly is based upon targeting the vulnerabilities and differences of cancer cells. Like cancer cells, their main energy source is glucose. So before applying chemotherapy, we target their glucose dependency. Cancer cells have heat sensitivity, so we target their sensitivity to heat. Cancer cells thrive in hypoxic environments, so we target that. And also cancer cells, as I said, similar to our chemotherapy, cancer cells application with cancer cells thrive on glucose, so we apply a ketogenic diet, which both there's large evidence about the ketogenic diet and slowing progression in cancer, and that has long-term metabolic effects, both about slowing progression of cancer, but also aiding in lowering conventional treatment side effects also. So it's a combined treatment protocol, which combines a conventional approach with also a metabolic approach to treating cancer. And so the current hypothesis behind the current conventional therapies is that cancer is a genetic disease, and these genetic mutations shall be targeted in treatment. While on the other hand, the Warburg hypothesis says that cancer is a disease of metabolic dysregulation, and there are much evidence that shows that the mutations seen in cancer cells are a downstream effect of this metabolic dysregulation. Meanwhile, what we say as clinicians is that and then practicing physicians and treating cancer patients. So we say, yes, this metabolic dysregulation is seen in cancer cells. So let's use this difference and vulnerability in treatment. Also, let's also use the genetic approach to treating cancer also. And our main thing is forming a harmony between metabolic therapies and also conventional therapies.
We would like to take a moment to thank our Patreon subscribers for helping to make this program possible. If you would like to have access to exclusive content, including transcriptions, episode recaps, and special offers, become a patron today at patreon.com/mossreports.
So when you say use the genetic approach, I mean, basically you're talking about using targeted agents, basically?
We can use, we sometimes use targeted agents. It's not a large portion of our treatments, but also even standard conventional therapies are standard conventional old chemotherapy drugs, even because they target the cell cycle, like and then it's mainly causing it's a pro-oxidant treatment, and are different chemotherapeutic agents. Some of them will target the S phase, some of them will target other phases of the cell cycle. So it's in the end, it's not as targeted as our current targeted therapies, but it's a cell cycle based treatment, are all conventional drugs. So it's using those kind of drugs also with metabolic therapies also.
Yes. And basically, I mean, even if you don't believe the Warburg hypothesis that cancer originates in the mitochondria, in other words, in the energy generating portion of the cytoplasm of the cell, there's still a trend now to recognize the fact that from the conventional point of view, that some of these genetic changes that are happening in the cancer cell affect energy metabolism. So there's been a backhanded recognition through the so-called hallmarks of cancer, the revised hallmarks of cancer of Hanahan and Weinberg, that energy metabolism is also a proper target for cancer drugs. So kind of in a backhanded way, the establishment has acknowledged what Warburg said starting in the 1920s, that cancer is a disease characterized by abnormal metabolism. We've gone through almost 90 years now of development of this idea, and kind of came back to where we started, that regardless of how you ultimately view the origin of cancer, there's something weird about the way that cancer generates energy, gets its fix of energy, and
Definitely.
that's a proper target. And we don't really have a handle yet completely on that. But one of the things that we see is that, of course, if you fast, after about 12 hours of fasting, autophagy sets in, meaning that the cells start to go into a phase of self-correcting or detoxification. And at that point, what you're saying is the cancer is now under stress, because cancer has enormous, usually fast-growing cancers have enormous needs for glucose. And if you fast, after a certain point, your blood sugar starts to go down, and the cancer is crying out for its fix, its sugar fix, right? It's glucose, it's
Definitely,
blood
exactly.
glucose. And at that moment, you sort of kick it while it's down, because it's now you're going to hit it with chemotherapy, you're going to hit it with heat, you're going to hit it with oxygen. So just using these very simple
It's a quite
tools.
like, it's just like hundreds of years ago, before, like if we think about the wartime, like
Yeah.
hundreds of years ago, before attacking a city, armies gathered around the city and cut the food source, the food supply, before attacking that city. It's just that a similar kind of analogy, and also just to wind back to what you said, as you said, like right currently, the dysregulated and energy metabolism is currently stated as an emerging hallmark of
Yes.
cancer.
Yes.
So this is a very serious point, because this is an evidently seen and starting to be accepted in conventional medicine. But
Right.
what's sad and disturbing is that bringing up the subject of targeting this difference is somehow seen as an alternative approach. Meanwhile, it's actually sound evidence based.
Yes.
It's a currently accepted emerging hallmark of cancer.
Yes.
What we're saying is, let's already, like, for the current in the 21st century, imaging wise, the current standard of diagnosing and following treatment response in cancer treatments is a PET scan, which is totally based upon the glucose dependency of cancer cells. And we use PET CT scans in almost 95% of cancers. It's a
Yes.
standard of practice. It's a guideline-based imaging technique, which is
Yes.
totally based upon glucose dependency. So we're saying, let's apply a treatment that is in harmony with the way that we image this disease. If we use this imaging technique, then why not Why not use a treatment protocol that's in harmony with the way that you image this disease?
Yes. And there's no answer to that. I mean, it's just a complete disconnect in medicine. The same doctor who will interpret the PET scan based upon the
Yeah.
uptake of this FDG, which is basically a radioactive form of sugar, will turn
Yeah.
around and tell the patient, no, there's no relationship between the intake of sugar and cancer. And 5 minutes before,
Exactly.
he was telling them, "Oh, your cancer is advancing because we see that the so-called SUV max, the amount of glucose substitute taken up by the cancer, has gone up," and then they're saying, "No, there's no relationship between the intake of sugar or carbohydrates." And so, I think this is just, like paradigms fall when there are too many contradictions that are just swept under the rug. And I think this is a case where the paradigm is giving way. What it will substitute, we don't know. But even the fact that Hanahan and Weinberg called this an emerging hallmark. It's been emerging since 1924, but it can't quite make it into, because they know very well, interpreting what they write. I think they know very well that once you open that door, a lot of other things come rushing in. Meaning, you have to change
the paradigm. It will change the paradigm.
Exactly.
That's the whole issue.
And paradigms always fight to maintain themselves. That's why they're paradigm.
Exactly.
But the other thing I wanted to ask you about was immunotherapy. And what's your take, even since we spoke last? I mean, there have been a lot of developments, and we've seen, James P. Allison at MD Anderson shared the Nobel Prize 2 years ago for his discovery of his discoveries leading up to the drug Yervoy, and the people who discovered the drug, the discoveries leading up to the formation of Opdivo and Keytruda and Tecentriq and so forth. And these have become huge factors in the worldwide market of cancer drugs. I'm wondering, how has that played out in Turkey, and how does that affect your and Dr. Berkard's theory about, or thinking about, the cancer problem overall?
Now, these treatments that you mentioned are new. It's a totally new treatments to the market, and they're mainly, most of these new drugs are so-called targeted therapies, and where the pharmaceutical industry has made huge investments in. But as clinicians, what we see as practicing clinicians, and also many other colleagues of ours also, the outcome that these drugs are yielding are not satisfying, unfortunately. What we see is much more basic approaches, just as doing a so-called ketogenic diet or a low carbohydrate diet, or some other basic metabolic therapies can improve outcomes much more than these so-called therapies. And we don't use them much because we haven't been satisfied with their outcomes. Also, and there are currently new publications coming out, which we're following closely also, that the side effect profiles of these drugs are not as they were priorly published about. Also, the expected median survival times aren't as expected also. So the efficacy and side effect profile has to be reevaluated, and also the cost issue in regard to these treatments also is a big issue. So my colleagues and other clinicians that aren't from our clinic, but which we talk and evaluate such therapies with, aren't too positive also about these therapies, unfortunately. We hoped for them to improve survival times much more, but unfortunately, we don't see that.
Okay. I just want to ask you, about the papers that you've published. Could you sort of outline one or two cases that you've published that you think would be of interest to our listeners?
Yeah, of course. Like, firstly, we made our first publications back in 2016. We published initially a rectal cancer case, a 81-year-old female patient, which we treated with a combined treatment protocol, which she was able to tolerate very well and went into remission. And we published about her around 2 years after follow-up that she was in remission. And our other paper that we published in 2016 was a case series of stage 3 and stage 4 pancreatic cancer patients treated at our clinic. And the median survival time of our patient group, which consisted of 34 patients, was 19.5 months compared to 6 to 11 months achieved with standard conventional chemotherapy. We made our third publication in 2017 regarding a stage 4 triple negative breast cancer patient of ours that went into remission following having extensive disease. And last year, in 2019, we published 4 new papers, which are our most important papers, actually. One of our papers, which we had spoken about when you visited our clinic, which I was trying to get published at that time.
Right.
It had been rejected by many journals, unfortunately. Our lung cancer paper, and we published it last year, and it's regarding stage 4 non-small cell lung cancer patients. And the overall survival time of our 43 patient case series is 42.9 months compared to 6 to 11 months in standard conventional therapies. And also, one important point is that our patient group had a much poorer outlook, as 40% of our patients had brain metastasis, and over 80% of them had poor performance status, and 100% of our patient group was stage 4. And we compared our patients' outcomes with other standard of care treatment protocols, applying the same kind of chemotherapy regimen that we applied in a metabolically supported fashion, but together with hyperthermia, hyperbaric oxygen, and the ketogenic diet. So besides that paper, we also published our outcomes in advanced gastric cancer, and again, a stage 4 patient group of ours. And our overall survival time in advanced gastric cancer is 39.5 months compared to 9 to 14 months in standard conventional treatment. And similarly, we published our outcomes in stage 2 and 4 rectal cancer patients, and with again extended survival times compared to standard. And we again made a new publication in pancreatic cancer with only adding our stage 4 patients only, and which reported 15.8 months compared to a very poor outlook of 3 to 6 months in these kind of patients and standard treatment protocols. And so it's been 7 publications, and we'll be making a new publication in these upcoming months, again in breast cancer. It will be our 8th publication. It's going to be regarding an outstanding treatment outcome achieved in a very advanced breast cancer patient. So what we are currently seeing following practicing this kind of approach to treating patients. It's been around 10 years now, and we're turning back and seeing have we achieved our goal of extending survival times in patients. And these publications are all about that. It's actually our own evaluation of our approach to medicine currently. And we're sharing what we're achieving with our scientific papers with our colleagues. And what we currently see is an approach these publications show that while planning cancer treatment, taking the metabolic basis of cancer into consideration and targeting multiple metabolic and cellular vulnerabilities might improve treatment outcomes. And so what we're saying is, yes, let's apply treatments in our guidelines, but we can apply them in a different way. We can apply chemotherapy in a metabolically supported fashion. It's a very basic approach. It's just what's needed is we have to accept that this disease has glucose dependency, and that lowering glucose availability to tumors will cause metabolic stress on cancer cells, and that this stress can be used to increase the efficacy of chemotherapy. But of course, to be able to apply chemotherapy in such a way, we have to accept that this disease has a glucose dependency, and this can be a metabolic vulnerability that can be used in treatment. And together with this kind of a way to apply chemotherapy, we can use other metabolic differences and cellular differences and as treatments. And we're currently using hyperthermia, hyperbaric oxygen, and the ketogenic diet. Also, together with these treatments, we also extensively use many different supplements and also repurposed drugs as part of our treatment protocol. And we're open to every kind of treatment. Like a while ago I said, yes, these new immunotherapies or new targeted drugs, yes, they aren't yielding the outcomes that we hoped for, but are we using them in some patients? Yes, we are. Are we using targeted drugs in some cases? Yes, we do. So we aren't against anything that's evidence-based, but we always are striving for better outcomes, and we're trying to incorporate every kind of treatment that will yield the best for our patients.
Yes. And what has been the response of your colleagues, either in Turkey or abroad, to perhaps the idea of doing a randomized control trial eventually to test these outcomes? Because the numbers you're reporting are pretty startling. 42-month survival, and I think you said stage 4.
Stage 4 non-small cell lung cancer.
I mean, that's unheard of in terms of conventional therapy. You're talking an average of 3.5 years of survival in stage 4 lung cancer. So you would think, or the listener might think, well, of course, the people who are treating lung cancer and only getting less than a year survival would be tremendously interested in this. So what has actually been the response of your colleagues?
Unfortunately, many of our colleagues, it's easy to just label people or clinics as alternative practitioners, but they aren't aware. Most of them don't even read these publications, unfortunately, even though that we send them to them, because everything's unfortunately. It's just you initially have to be open to the idea, but we don't see that openness by many of our colleagues, not only national but in an international field also. But we think with time, many clinicians are going to come to a similar point that we have, and especially Professor Berkarda has come after practicing for standard conventional for 30 years or so. He came to asking questions. We believe also that many of our colleagues with time, and we hope they'll come to a similar point of asking questions and searching for what else can be done and how outcomes can be improved. And that's why we're publishing, and we hope that our publications will be a cornerstone in this field where other clinicians can look at and incorporate our kind of approach into their patients' treatments. So currently we we haven't seen what we've hoped for from our other colleagues, but we still hope, and that's why we're still always constantly trying to publish more papers, so other clinicians can also go down a similar route. And in all of these papers, we're giving all of the details necessary to apply such treatments. We explain how we apply chemotherapy. We explain when and how we apply hyperthermia. We explain how we do the diet, how we apply hyperbaric oxygen therapy. All of these are in our publications, and hopefully it will be in the near future where many other clinics worldwide will be applying this kind of a protocol, which we believe and which we see gives the best and much better compared to standard to patients suffering from cancer.
Thank you so much. That's a very, very good summation of the work of the Chemothermia Clinic in Istanbul. And I want to thank Dr. Abdul Slocum, and of course, my best regards to your colleagues, including Dr. Berkarda. I think I did, maybe I got it right that time. For the wonderful work that you've done. And I look forward to seeing further reports from you and hopefully visiting again soon in the future.
Thank you. Thank you very much. Thanks for inviting me to your podcast, and it's been a great pleasure to talk to you.
Yes.
And I and my colleagues, we really look forward to seeing you again at our clinic.
Thank you so much. Bye.
Thank you. Bye-bye.
Thank you for listening to The Moss Report. Visit our website at themossreport.com and subscribe to hear more discussion of cancer treatment options, alternative research, and more. For more information about Dr. Moss and his work, including scheduling phone consultations, go to mossreports.com.